Good morning. I too would like to thank Professor Toppelchon for this invitation. As many of you know, Professor Toppelchon has now been organizing this meeting for many years, in fact, probably decades, and it's always a great pleasure to come here. So thank you, Professor Toppelchon. So my talk is more specific than that of Raphael's. It's specifically on ovarian cancer. So, a brief introduction to ovarian cancer. It's a relatively rare malignancy. However, it is one of the most lethal malignancies affecting women. And the main cause of this high lethality or aggressiveness is not related to biology as far as we know. It's related to the fact that most cases of ovarian cancer are diagnosed at the advanced setting. Raphael mentioned that I think 20% of patients presenting at his hospital have metastatic malignancy at initial presentation. That may be the situation across the board in general for patients presenting with metastatic malignancy. But for ovarian cancer, the vast majority of women present with metastatic disease. So this slide here gives an indication of the aggressiveness, of the lethality of ovarian cancer. And a good way of expressing and comparing lethality of different cancers is to relate the number of deaths per cases per cases diagnosed as a percentage. And one of the most lethal cancers is lung cancer, and approximately 70% of patients diagnosed with lung cancer die from their disease within 5 years. Now, with ovarian cancer, the lethality is almost as high. I don't think this point is generally known, that the lethality for ovarian cancer approximates that of lung cancer. And you can see that the lethality for, sorry about that. The lethality for some of the more common cancers, such as colon, breast, and prostate, is considerably less than that of ovarian cancer. Now, traditionally, ovarian cancer was referred to as the silent disease. So the prevailing view was that there were usually no symptoms until advanced disease was present, i.e. when prognosis was dire. However, a few years ago, this concept of the silent disease, that ovarian cancer could no longer be regarded as a silent disease, this concept was shall we say, was quashed when Barbara Goff et al. Published a classic paper in Cancer. And Goff et al. Described a number of symptoms that all of these symptoms are common, but if any of those symptoms occurred less than or greater than 12 times per month for less than a year, there was a high probability of ovarian cancer. So I think today ovarian cancer can no longer be regarded as a silent disease. So this slide here summarizes the predictive value of these symptoms, the so-called symptom index. So in a study published in JNCI a number of years ago, 800 patients with ovarian cancer were included, 1,300 controls. Women with the symptoms were 10 times more likely to develop ovarian cancer than the controls. But the symptoms, the interesting point was that the symptoms were present for both early as well as late stage disease. And the symptoms were present in 27% of the women more than 5 months before disease was detected. So these symptoms, if they occur with the frequency as outlined in that paper, should not be ignored. Now, a lot of the research in cancer these days is focusing on genetics and genetic alterations that occur in different cancers. And there is one standout genetic alteration that overshadows all the others, particularly in the high-grade serous ovarian cancer. And that is that the p53 gene is mutated in effectively 100% of patients with the worst form of ovarian cancer, high-grade serous ovarian cancer. Now, this predominance of mutations in p53 and relatively low prevalence of mutations in other genes is somewhat unique to ovarian cancer. If you take breast cancer or colorectal cancer or lung cancer, there are usually a few genes, not just one, that are commonly mutated. But at least in high-grade serous ovarian cancer, p53 is the standout gene. So I think if we came up with a good target for mutant p53, we could make significant inroads into ovarian cancer. And there are currently, as far as I know, at least 2 trials, early trials ongoing with drugs that are aiming to target mutant p53 in advanced serous ovarian cancer. So most of my talk will focus on markers in ovarian cancer. So over the years, a large number of markers have been proposed for ovarian cancer. Perhaps the most widely used is CA125, HE4 is used in some centers, Raphael may use additional markers, but for most labs, CA125 is still the only widely used a serum marker in ovarian cancer. The question is, which of these is the best marker for ovarian cancer? Which is the best marker for the early detection of ovarian cancer? I'm not referring to the situation where a woman is symptomatic at this stage. What I'm referring to here is the early detection of ovarian cancer. For example, screening. Well, this study published in Cancer Preventive Research some time ago, this is an excellent study, and I think it illustrates how to identify and discover markers for early cancer. So this group, they looked at 35 markers that were previously proposed for ovarian cancer. But the almost unique feature of this study is that the samples were taken before the women had any diagnosis. Now, most studies on markers in early cancer are aimed at detecting early cancer. They're usually carried out in patients that are already diagnosed with cancer. And that should not be the aim of developing a new screening marker for cancer. You should be able to detect it when the individual is in an asymptomatic state. And even the high-profile publications by the Johns Hopkins group on circulating tumor DNA, which were published recently in Science and Science Translational Medicine, etc. One of the problems of these studies is that they use patients who already had diagnosed cancer. But in this study that I'm going to show in this and the next few slides, blood was taken from subjects in an asymptomatic state. So these markers, all of these were compared at a 95% specificity. So they were pre-diagnostic sera. They were sera that were used in the so-called PLCO screening trial in the United States. Of the 25,000 patients, 118 had ovarian cancer. There were 24,000 controls, and out of the 24,000 controls, 955 were selected because they matched the ovarian cancer patients. So for this comparison of the various markers, there was sera from 118 patients that were subsequently diagnosed with ovarian cancer, and 951 women who were still asymptomatic. So what results turned up? Top of the list, the most sensitive marker by a long way was actually CA125. HE4 was down the list, and all the other markers that are at least shown in this slide had lower sensitivity. So I think this slide, I think is pretty good definitive evidence that CA125 is the best single biomarker for the early detection of ovarian cancer. Now, the situation in women with pelvic masses may be different, as I'll come to later. Now, these investigators also looked at the levels of these markers at different time periods prior to the diagnosis of ovarian cancer. And I'm showing the data for CA125. So the sensitivity for CA125 at 0 to 6 months, 0.86, but going back longer than 6 months, the sensitivity, as you'll see, was not great. So this brings one to the question, does screening with CA125 reduce mortality from ovarian cancer? We hear a lot about the use of PSA in screening for for prostate cancer. We hear less about CA125 in screening for ovarian cancer. Well, a number of studies, I think 4 or 5 randomized trials have been carried out around the world to address whether CA125 screening reduces mortality from ovarian cancer. I'll show the results from the 2 of the largest trials. First of all, why screen? Well, it's obvious. As I said at the start, more than 70% of patients are diagnosed with advanced disease. The 5-year survival for women with this advanced disease is dire. However, if ovarian cancer was diagnosed at an early stage, the outcome would be similar to that for patients with breast or colorectal cancer or whatever. So the reasons, the rationale in screening for ovarian cancer is pretty clear. But the challenges, there are big challenges in screening for ovarian cancer. Firstly, there's no pre-malignant lesion as far as we know, or it hasn't yet been identified. But I think we may in the future be able to identify a pre-malignant lesion for ovarian cancer, because what has emerged in recent years, at least in the aggressive form of ovarian cancer, the so-called high-grade serous ovarian cancer, that it seems that this malignancy does not start at all in the ovaries. It seems to begin in the fallopian tubes. Now, this was quite a revolution in thinking, and it has emerged, and the evidence has grown more and more, that the origin of ovarian cancer, the high-grade serous form, occurs in the fallopian tube. So rather than looking in the ovaries for a pre-malignant state, maybe the focus should be on the fallopian tubes. Another challenge in screening for ovarian cancer is its relatively rarity, approximately 40 cases per 100,000 postmenopausal women. The consequences of positive screening is surgery, and surgery for ovarian cancer is pretty major surgery. So there is the possibility that the complications of surgery for false positive results will outweigh benefits of early detection. Now, a number of years ago, various investigators, particularly Ian Jacobs, who was then working in London, came up with the criteria that any test should have if it was to be reliable enough to screen for ovarian cancer. And first of all, in screening for most malignancies, and particularly ovarian cancer, they specified that the test should have a specificity of greater than 99.6%. Now, this is a tall order, this type of specificity. The sensitivity should be greater than 75%, and to get, and this combined sensitivity and specificity should then give a positive predictive value of greater than 10%, which was felt should be necessary in screening for ovarian cancer. Now, most of the screening strategies that have been investigated have not used CA125 alone, but they have used what's referred to as multimodal screening, where CA125 is combined with ultrasound. The two large trials, or the two largest, one carried out in the UK and the other carried out in the US as part of the PLCO trial. So in the PLCO trial, 78,000 women were randomized to screening or usual care. Screening was pretty intense. The women in the screening arm had annual CA125 measurement for 6 years and transvaginal ultrasound for 4 years. Median follow-up relatively long, 12 years. So, the first indication that a screening trial may be effective, in other words, that it may be reducing mortality, is that if you get a stage shift, in other words, if you get more patients diagnosed with early malignancy in the screening arm vis-a-vis in the control arm. So, when the authors of this trial looked for a stage shift, they found certainly a trend. There were more patients diagnosed with early stage than those in the control arm, but this difference was not significant. Stage 3 and 4, you'd expect a drop, a significant drop in stage 3 and 4. That wasn't found. CA125 levels, however, were significantly higher in the control group than in the trial patients, but the number of high-grade serous tumors, the aggressive form, as I said, were not different in the so-called control group and the trial patients. So that preliminary data didn't augur well for a reduction in mortality in this trial. But when the authors did look for a mortality reduction, unfortunately, they found no difference in number of deaths. So this was a good study. There were many problems with the PLCO PSA screening trial. This ovarian cancer component of the PLCO study was a good trial. It didn't have the same problems, the same disadvantages as the prostate screening arm or component of the PLCO study. Disappointing. But even worse than the trial not finding a reduction in mortality was the number of false positive screening tests, over 3,000. And these led to over 1,000 surgeries. And from these surgeries, there were 163 serious complications. So what the conclusion from this trial was that not alone did the screening not reduce mortality, but it led to, it did more harm than good. Now, turning to the UK study, over 200,000 patients. There were 3 arms to this study: ultrasound plus CA125 or no screening. And unlike the American trial, what the UK investigators did, they didn't rely on a static CA125. Rather, they looked for a dynamic a change in CA125. If the CA125 increased, it led to an ultrasound. If the CA125 level stayed static, it was checked at a later time. So what did this trial conclude? It concluded that mortality reduction with ultrasound was 11%, but not significant. Mortality reduction with ultrasound and CA125, 15%, not significant. But what was significant, when the investigators looked at the mortality reduction with ultrasound and CA125, in years 7 to 14, they did find a reduced mortality. So there's some hope that this approach taken by the UK investigators will lead to a reduction in mortality. So what they're planning to do is reanalyze the data with further follow-up, and I think this reanalysis is going to occur next year. And personally, I think when this data is reanalyzed, the combination of ultrasound and dynamic measurement of dynamic or changes in CA125 will show a reduction in mortality. So just, we're now in March. Last month, the United Services Preventive Task Force actually issued updated guidelines on screening for ovarian cancer. Now, over the years, various guidelines have been published on screening for ovarian cancer, but this is the most recent, published in JAMA last month. And this is what the USPSTF group concluded. Given the lack of mortality benefit of screening and the moderate to substantial harms that can result from false positive screening tests and subsequent surgery, this group concludes that the harms of screening for ovarian cancer outweigh the benefits, and the net balance of the benefits and harm of screening is negative. So, screening for ovarian cancer not recommended at this stage. Now, moving on to women who present with pelvic masses, a different situation to the screening context. So, pelvic masses occur in approximately 10% of women, in approximately 10% of premenopausal and 30% of postmenopausal women. These masses can be malignant. Differentiation between the two types of pelvic masses is important, as women likely to have ovarian malignancy should be referred to a specialist in gynecological oncology surgery. Although we've been reading this type of a statement for many years, I believe that still in the United States, most women presenting with a pelvic mass are not referred to a specialist center. I don't know what it's like in this country, but I think in a number of Western European countries now, women who present with the pelvic mass, they do have a range of markers and ultrasound measured, and if suspicious, they are referred to an expert center. So what's the best marker for differentiating between benign and pelvic masses? A different question to what I addressed earlier. Well, Moore et al., in a publication 2007, looked at all of these markers. So what did Moore et al. Come up with? Well, clear. When Moore et al. Looked at sensitivity, it's clear that HG4 had the highest sensitivity. And for specificity, yes, it also had the highest sensitivity and specificity, as you see there. But they also combined HG4 and CA125, and the sensitivity increased a little, and also the specificity appeared to increase. Later, CA125 and HG4 and menopausal status were combined into this term that we refer to as ROMA. So now we had 3 possible tests, or biomarker-related tests, for ovarian cancer in differentiating pelvic masses. So which is best? Well, there are probably hundreds of publications in the literature claiming that ROMA is best, or that HG4 is best, or that CA125 is best. And Raphael has published major studies on this. Now, I'm not going to take any individual paper, because I could take any individual paper and make any point I wanted to. So the data that I'm going to show is from a meta-analysis. There are problems with meta-analysis, but they probably are better than any single study unless it's a high-level evidence study. So, Lee et al. In this meta-analysis, they combined 11 studies over 3,000 patients. So sensitivity, ROMA came out as being the most sensitive. The most specific was HG4. The likelihood ratio, HG4. So this meta-analysis would seem to indicate that HG4 may be the most reliable single biomarker for differentiating between benign and pelvic masses. I'm sure Raphael will have a comment on that. Yeah. Now, is HG4, is it recommended? In most guidelines, it's not at this stage. But EGTM do have a statement on HG4. And this is the EGTM statement on HG4 as regards its application in the differential diagnosis of pelvic masses. Because HG4 has been reported to have superior specificity to CA125, especially in premenopausal women, it may be considered either alone or as part of the risk of ovarian malignancy algorithm in the differential diagnosis of pelvic masses. Now, the detection of ovarian cancer can be difficult, and this is why it's diagnosed usually at an advanced stage. I'm going to illustrate one particular patient and describe her pathway to the diagnosis of ovarian cancer. This is a unique case history because it was written by a doctor, and she submitted this case history on herself to the BMJ, and it describes her passage from initial symptoms developing to the final diagnosis of ovarian cancer. And this is not unusual. 66-year-old, in September 2007, she had intermittent pain in her right side. She went along to her general practitioner, to her doctor, who diagnosed gallstones, but also sent her for an ultrasound. During the ultrasound, a kidney cyst was found, and this cyst was blamed for the pain. The woman was sent home, not to worry, told not to worry. The next year, her GERD expanded, and she thought it was due to middle-age spread. So, ignored it for a while, but the pain got worse. And in April 2008, she presented to a urologist. And this urologist suggested further gallstone tests. In May 2008, she was diagnosed with inflammatory bowel disease, and the cause was put down to pain, diarrhea due to Campylobacter. June 2008, she was getting fed up at this stage, decided to go to a different doctor. This doctor finally took blood and referred her to the Royal Free Hospital in London. The Royal Free Hospital referred her to University College Hospital, and eventually in July 2008, she was diagnosed with stage 4 cancer at this stage due to the blood being taken for a CA125 a couple of months earlier. So, in my view, I don't think this is unique. So, in the UK, this organisation, the National Institute for Care and Excellence, then decided to issue guidelines for what they claim the early detection of ovarian cancer in women with symptoms suggestive of ovarian cancer. So this is what they recommended. Measure serum CA125 in the primary care in women with symptoms that suggest ovarian cancer. If serum CA125 is greater than 35, arrange an ultrasound scan of the abdomen and pelvis. If ultrasound suggests ovarian cancer, refer woman urgently for further investigations. Now, there are significant caveats to the use of CA125 in the early detection of ovarian cancer in the primary care situation. And Kathy Sturgeon and myself were asked to write an editorial for the Annals of Clinical Biochemistry when these guidelines came out from Roche. And our title was, "There are significant caveats to the use of CA125 in the early detection of primary care." And we listed the various benign causes of CA125, as well as other malignancies that can cause elevated levels of CA125. But even so, despite these limitations, I think this recommendation by NICE to refer women who have the symptoms that I showed on an early slide for CA125 and subsequently ultrasound if elevated, I think is a good idea. And in my country now, we have taken up a similar practice for women presenting with these various miscellaneous symptoms that I showed on one of my first slides. So I think my time must be almost up, so I'll stop there. Thank you.